we welcome you all today, lovely Saturday evening, for the Perinatology Committee FOXY webinar on RH negative pregnancy. And thank you to TOG, Science Integra, and Bharat Serum once again for this series of RH negative pregnancy management webinars. In the beginning, I would like to thank Dr. Alpesh Gandhi, President, FOXY, for this opportunity, and ICOG for accrediting it as one ICOG point for this webinar. Dr. Mandakini ma'am and Dr. Parag Biniwale, Secretary ICOG. Sir happens to be with us today as a guest of honor. He is also the advisor of my committee, Perinatology Committee FOXY. So we'll be able to listen to him later on. ICOG is, as we know, the academic partner of FOXY. And there's a huge amount of research and academic work being done by ICOG. I urge all of you to whoever to go ahead and get the FICOG and pursue the academic interests in ICOG. We'll hear Dr. Parag more about ICOG from him. And as we start today, we have two eminent guests of honors, Dr. Parag Biniwale and Dr. Bhaskar Pal. And we also have an array of expert faculty, Dr. Arun Madhav, Dr. Indrani Roy, Dr. Queen Aditya, Dr. Nilesh Balkaude, Dr. Indranil Datta, Dr. Prasanna Roy. This webinar is Perinatology Committee FOXY along with 6 societies, and this has been arranged by our East Zone Coordinator of Perinatology Committee FOXY, that is Dr. Priyankur Ray. The societies with us today are Asansol Society, Bengal, Dibrugarh, Kalyani, Shillong, and Siliguri OBGY Society. We are indeed very thankful to the President and Secretaries of these societies, Dr. Sabyashi Gupta, Dr. Dibendu Banerjee, Dr. Arun Madhav, Dr. Nayan Sarkar, Dr. Umlong, and Dr. GB Das. Perinatology Committee FOXY has been doing a lot of work over the past 2 years since I have taken over. We have done more than 100 CMEs, workshops, social programs, hands-on drills. We had a program, Sat Sat, with Dr. Malhotra ma'am, where the pediatricians and the IAP and NNF, all the associations were associated with us. Last year with Dr. Nandita, we launched a FOXY focus on preterm labor. We have done a lot of hands-on drill on NRP, and this year the committee is doing a lot of work under the guidance of Dr. Alpesh Gandhi sir. So to begin the program, I would like to welcome our two guests of honor, Dr. Parag Biniwale and Dr. Bhaskar Pal. Introducing Dr. Parag Biniwale, sir is a senior consultant OBGYN. He's unit head, PG teacher at Kamala Nehru Hospital. He's Secretary ICOG. He's President of Menopause Society Pune. He's National Joint Secretary IMS. He was in 2017-18. He was Chairman Young Talent Promotion Committee FOXY in 2008-10. He has contributed to numerous books, journals, articles, and publications. And he is a good dear friend, a true guide and mentor for all of us here at Pune, and especially for my society, for my committee, Perinatology Committee FOXY. Welcome, Dr. Parag.
Thank you. Thank you, Vaishali, for the invitation. It's a pleasure to be associated with this committee as an advisor, and I must compliment you for doing wonderful work that you are doing for last 2.5 years, and just keep on doing this excellent work. Friends, I bring greetings from ICOG, the Indian College of Obstetricians and Gynecologists, which is the academic wing of FOXY. ICOG, all of you know, was established way back in 1984, and it's basically all about academics. So in this activities that are being carried out by ICOG include 6-month certification courses, which include reproductive medicine, ultrasound, perinatology. We do have vaginal surgery. We do have hello, Vaishali, can you hear me? My internet is a little unstable. Okay.
We can hear you.
Right. And during these COVID times, we've gone We've tried to reach out to people by the my medium of webinars, and we have online courses. We did have one on contraception, which is currently going on. There's one on oncology. We did have one on adolescent gynecology, and hopefully we will have one on polycystic ovarian disease very soon. So I appeal each and everyone who's attending this webinar to join ICOG. Senior members who are 10 years into post-graduation and member of FOXI for 5 years can certainly apply for fellowship of ICOG. And for fellowship, you need to have 3 publications. And if you don't have 3 publications, you can always collect 100 ICOG credit points, and that too through the medium like webinars or conferences, which are accredited by ICOG. So today's webinar is accredited by ICOG by giving 1 credit point. So ladies and gentlemen, please join more and more academic activities and join ICOG. Thank you very much. Thank you, Vaishali.
Yeah, thank you, Dr. Parag, for your guidance, and I'm sure more and more people will join ICOG. And thank you for all your support, especially for my committee, Perinatology Committee, FOXI. I would also like to welcome Dr. Bhaskar Pal. He is our guest of honor today. Dr. Bhaskar, is he there?
Yeah, I'm there.
Yeah. Dr. Bhaskar, thank you for being here with us today. He is, as we know, is a national leader. He's treasurer of IAG. He's senior consultant gynecologist, Apollo Hospital, Kolkata. He's honorary general secretary in IAG, chair RCOG, India is International Representative Committee, President-elect, Bengal OBGY Society, Vice President, FOXI 2017. And Bhaskar, you have been always guiding my committee, even the FOXI focus, which we did last year. You were one of the authors, and you really helped me, prepare the index and the topic. So you have always been very helpful to us. Thank you very much. And we would like you to say a few words to us.
Thank you, Vaishali, for the kind invitation. I think Vaishali and Vaishali's committee has been doing a wonderful job of doing these webinars, and especially taking up this issue of Rh negative pregnancies across the country. I think Rh negative is a very good example of what education can do to a disease. Many years back, when we were undergraduate students, we would see a lot of RHIC immunizations. These days, hardly you will come across any pregnancy where the baby is affected. And that is because of the way that anti-D has been taken up so widely. And this is where education makes a difference. It's an excellent job, Vaishali. And also, it is great to see that 6 societies are together. Not only that, and it is essentially a youth power packed panel. We have, I think, Dr. Priyankur Rai, the upcoming star of the East, giving a talk. And then we have Indrani, Indronil, Nilesh, and Queen and Prasanna being in the panel. And I have my elder brother, Dr. Arunmadha Barua. I think it will not be inappropriate to say that this is the election season. And all of you have done wonderful job, and many of you are contesting for elections. So I wish all the best to Vaishali for her ICOG Governing Council elections, Nilesh for his election to the chairperson of the quiz committee of FOXI, Indranil to his election to the chairperson of the practical obstetrics committee of FOXI, and last but not the least to Arunda, Dr. Arunmadha Parua. For those of you who do not know him, it is very difficult to find as nice a human being as Arunda, apart from everything else. And we would like to see Arunda as the vice president of FOXI from his own. Thank you. I wish you a very good program and many more successful programs ahead.
Yeah. Thank you, Bhaskar, for those very kind words, and for wishing us, all of us who are contesting, for your wishes. Thank you very much. It really means a lot that you have been here today. You are here to guide us. So thank you, Bhaskar. And we move on. It was indeed privilege for both of our guests of honors to share their valuable, advice with us. So we move on with the scientific program now, and I request Dr. Priyankur Roy to come start the first talk on role of immunoglobulin in Rh negative pregnancy. And we introduce Dr. Priyankur. Yes, Priyankur is first of all, the entire program has been organized by Priyankur. So congratulations, Priyankur, for doing this. And he, as we know, is a very dynamic young Foxy worker. He has fellowship in infertility and gynec endoscopy. He's consultant infertility endoscopic surgeon from Siliguri and India representative for VETOG PIGO 2018-21. He's East Zone coordinator for Perinatology Committee Foxy as well as for Infertility Committee Foxy, and he has been really doing active work for both the committees. He's recipient of gold medal for topping in MS University examination and has received numerous awards. He has delivered a Kamini Rao oration in 2020, and he has lot of publication articles, national and international journals. And the Yuva Foxy, which he organized last year, is indeed quite memorable. So Priyankur, welcome. Please go ahead with your talk.
Thank you, ma'am, for the kind introduction. I'll just share my screen. Is it visible?
Yes, yes.
Okay, so today the topic given to me to talk on is role of anti-D immunoglobulin in managing Rh negative pregnancies. As Dr. Bhaskar Palsar has mentioned, Rh negative has been a disease or has been a pathology which has taken a backseat nowadays because of increased knowledge and because of increased surveillance or increased the physicians becoming more sensitive to it. And so the Rh negative pregnancies get picked up, the anti-D is administered, and hence the complications have become lesser day by day. So if you look at the epidemiology, this is not to say about the vast population of Spain, which we all know has a maximum incidence of Rh negative pregnancies, approximately 30 to 35%. But just to mention over here that the Asians and others, the incidence of Rh negative pregnancies is only 2% or less, and thus it's the onus is on us to decrease the complications of these pregnancies as much as possible. So I will not go into the basic of anti-D that we all know from our text, and we have all read about it. I'll just go into a few advancements and a few things that have really come up in the last few years. So just a little bit of a theoretical part, that is the sources of anti-D. It's manufactured from a pooled plasma from those who with high titers of IgG antibodies to D positive erythrocytes, once produced from the plasma of alloimmunized women. Now the male donors who undergo repeated injections of D positive red cells develop high titers to antibodies. The scarcity of resources has led to a search for a synthetic anti-D immunoglobulin, and potential future advantages of a synthetic product over products derived from humans include great availability, elimination of risks of pathogen transmission, and adverse reactions due to impurities in plasma. In this COVID era, where we know that infections, viral infections, etc., is a major deterrent to any sort of treatment, thus we know that, of course, if it's a synthetic molecule or a synthetically produced substance, then the chances of the risks of various infections like HIV, hepatitis A, C, B, etc. is a lot lesser, and I will come in the subsequent slides and I will talk to you how this infections can also be reduced further. So the dose that we normally give is just a revision of what we usually do, is 300 microgram, that is equivalent to 1500 international units, and it contains anti-D to suppress the immune response to 15 ml of D positive red cells or 30 ml of D positive whole blood. So, so it's very important for us to know this, that it's 15 ml of D positive red cells that is neutralized with this regular dose, and thus what I mean to say by this is, once we realize or once we suspect that the amount is more than 15 ml of D positive red cells, then we might have to go in for an increased dose of anti-D. A single 50 microgram dose contains sufficient anti-D to suppress the immune response to 2.5 ml of D positive red cells. So this is the dose that we usually give in abortions that happens lesser than 12 weeks of gestation, considering a normal fetal-maternal exchange and not a higher exchange. The half-life, the mean half-life is 24 days. In a small population of patients and with highly sensitive assays, as long as 95 days after a routine antepartum injection, and possibly as long as 180 days, that is 6 months. So the mechanism of action, epitope masking is not thought to be the primary mechanism. Reason being that is a significant number of D antigen sites on fetal RBCs in the maternal circulation are not bound by passive anti-D immunoglobulin. The fetal red cells coated by anti-D are rapidly cleared by a macrophage-mediated process and or down-regulation of antigen-specific B cells before an immune response occurs. Efficacy without the use of anti-D, approximately 16% of D-negative women become alloimmunized after 2 deliveries of D-positive ABO-compatible infants. The rate falls to almost 1 to 2% with routine postpartum administration of a single dose of anti-D, and it falls further to 0.1 to 0.2%, actually, we can say 0.3% as well, with the addition of routine antepartum administration in third trimester. So we can see the difference, 0.1% as compared to 16%, and thus the administration of this molecule definitely needs to be there. De-alloimmunization has not been completely eliminated. This is because of failure to administer the anti-D in accordance with published guidelines and because of unsuspected fetal-maternal bleeding early in gestation before administration of the third trimester prophylaxis. Risks of anti-D immunoglobulin, a few only, that is risk of fetal anemia. This is for more of a theoretical reason, and also, of course, for sometimes counseling a patient, those so-called Google patients who come and ask you what could be the risk. I have read about all this, and does this really happen? So enhancement of maternal primary immune response to D-positive red blood cells, adverse obstetric outcome, reduced maternal response to postpartum rubella immunization, short or long-term harm to fetal immune system, and there is no evidence that maternal administration of anti-D immunoglobulin results in any significant risks. So this should be the tagline, and this should be explained to the patient once they ask you questions after explaining what risks there could be, but the ultimate thing is that it does not increase any significant risk as compared to the benefits that should be mentioned. So the infection and allergic reaction, plasma units for making anti-D are tested for antibodies to hepatitis C virus, hepatitis B virus, HIV, and parvo-V19 virus. Corn cold ethanol fractionation followed by viral clearance ultrafiltration are highly effective for removing viral particles such as hepatitis A and C, parvo-B virus, B12 virus, and HIV. Anti-D prepared by this method, example, hyper-RHO SD, ROGAM, Bay-Ro-D must be administered only intramuscularly, but the preparation of anti-D by ion exchange chromatography isolation, that is in Rho-Phylac, are purer and can be given intravenously as well. So the general approach, the thing that we usually do in our routine practice, all D-negative pregnant women should undergo an antibody screen ICT at the first prenatal visit of each pregnancy. The blood test is accurate and inexpensive relatively. If antibodies are identified positive, she is counseled about continuing pregnancy, utilizing interventions of predicting the risk of HDFN and diagnosing and treating severe fetal anemia. Screen positive women should not receive anti-D. So who are the candidates for receiving this immunoglobulin? They are the D-negative women with negative IgD and who are pregnant and are the candidates for anti-D. It should be given but nowadays we have come around with another theory in which two antenatal anti-D administrations are being talked about and are being practiced in countries like UK, France, etc., which I will tell you later. After delivery, if the newborn is D positive, then postpartum anti-D needs also to be given. In addition, after an antepartum event associated with the increased risk of fetal-maternal bleeding, and D-negative women who are carrying a D-negative fetus does not benefit from anti-D immunoglobulin. So okay, this is another thing that we need to remember. This just giving you an example. When I was doing my internship in a rural hospital associated with CMC Vellore, there was a lady whose blood group was Rh negative and the husband was also Rh negative. But it's a routine protocol in the labor room over there that once the baby is born and if the mother was Rh negative, the blood is usually sent to the laboratory. So, so the blood was sent, and it's a rural hospital, so the patients do not afford much. And usually, if the husband is also negative, then the blood is not sent. And once the blood was sent for the blood grouping for the baby, the report came out to be positive, to the surprise of everyone. And we all know what the reason is. But then Yeah, so in some instances, the blood group, once the mother's blood group is negative and the baby's blood group once it's done, and we always assume that once the husband's blood group is negative, the baby will always be negative. But for the benefit of for the mother's benefit, we should always do the baby's blood group, irrespective of the fact whether the husband is negative or positive. So if the biological father of the fetus is known with certainty to be D negative, then the antenatal anti-D may be omitted, but make sure that the blood group of the baby is done, and only if it is negative, then only it should be omitted. Assurance of paternity in these cases better be documented in the medical record, because a meta-analysis revealed a median incidence of 3% of issues related to paternity. That is what exactly the point which I wanted to relate to the incidence in CMC Vellore. So use of cell-free fetal DNA and fetal D-typing of maternal blood. This is the new thing that has come up. Basically, it's a little controversial though. If cell-free DNA results suggest that the fetus is male and D negative, then antenatal anti-D can be omitted. But if the fetus is female, then the result reflects the maternal rather than the fetal RHD gene. This could also be something to do with the grandmother phenomenon that we know theoretically, and because of that, again, the anti-D should be supplemented. The National Institute of Health in England recommends fetal RHD genotype as a cost-effective option to guide antenatal prophylaxis with anti-D immunoglobulin. An Australian study also conducted that RHD genotyping was economic and is a sound option. In 2019, a cost analysis available in the United States found that fetal RHD genotyping is not a cost-effective option. In Denmark, the Netherlands, Sweden, England, France, and Finland, fetal RHD determination is performed routinely in D-negative women. The advantages are over 1/3 of D-negative women appropriately avoided antenatal anti-D immunoglobulin. And the disadvantages, the selective approach has the potential to increase the number of cases of de-alloimmunization because of the possibility of a false negative result. So the prophylaxis is ideally given at 28 weeks of gestation. Antibody rescreening at 28 weeks will detect the rare woman who has become alloimmunized in the interval since the first screen. A single dose of 300 micrograms of anti-D is administered. In the UK and Canada, our two-dose regimen is used. 300 micrograms of anti-D immunoglobulin are administered at 28 and 34 weeks of gestation. There is a little bit of a controversy in which there was a study actually which was done and which compared 100 micrograms of anti-D immunoglobulin at 38 and 34 weeks in comparison to 300 milligram. And of course, the chances of isoimmunization was much lesser with 300 micrograms. And thus, this is what is recommended nowadays. A network meta-analysis found that the two-dose 24 and 34-week regimen of 300 micrograms was more effective than a single dose of 300 micrograms at 28 weeks for reducing the incidence of alloimmunization. So additional cover-ups need to be done in cases of spontaneous or induced abortion. The D antigen is detectable on embryonic red cell by 38 days after conception, that is 7 plus 3 weeks of gestation. Some groups do not recommend prophylactic anti-D if it is a complete spontaneous miscarriage before 12 weeks of gestation, but be sure that any case of instrumentation or any induced abortion where instrumentation was done, it should be given or it is recommended. Invasive prenatal diagnostic or therapeutic procedures like chorionic villus sampling, amniocentesis, amnioinfusion, fetal blood sampling, fetoscopy, etc. And also in case of multifetal reduction where this needs to be administered. Blunt abdominal trauma and external cephalic version, a controversy, but ideally should be given. In cases of ectopic pregnancy, fetomaternal bleeding may be transplacental or may result from absorption of fetal blood by the maternal peritoneum. Thus, it should be given. In case of threatened abortion, again, anti-D immunoglobulin is administered to women with significant clinical bleeding, not just spotting, since 20 to 40% of pregnant women experience spotting, and alloimmunization in this woman is rare. An incidental finding of a subchorionic hematoma or ultrasound examination is not an indication of antepartum prophylaxis. So antepartum bleeding in the second and third trimester, fetomaternal bleed would be higher with placental abruption than in cases of placenta previa, in which it just drains outside and there is no much of exchange that happens between the mother and the fetus. In case of fetal death in the second and third trimester, can be an alloimmunizing event when caused by massive fetomaternal hemorrhage or occult abruption. In case of hydatiform mole, a complete mole does not contain fetal red cells, but prophylaxis after evacuation is suggested in partial molar pregnancy. Also give anti-D when the type of pregnancy cannot be determined correctly. The dosage first trimester is 50 microgram, but there is no harm in giving 300 microgram if 50 microgram dosage is not readily available. And in the second and third trimester, 300 microgram is the dose that is recommended. Recommendation is to monitor the maternal ICT every 3 weeks in women with recurrent antepartum bleed who have received prophylaxis. If the result is positive, indicating that anti-D immunoglobulin from the previous dose of prophylaxis is still present, no additional treatment is necessary. If the result is negative, then the woman may not be protected. In these cases, a test to evaluate the volume of fetal red blood cells in maternal circulation is obtained, and a repeat dose of 300 micrograms of anti-D immunoglobulin is administered. For testing for fetal-maternal bleeding, the incidence of large fetal-maternal bleeding is approximately 1 in 200 to 300 deliveries. These are beyond the limit covered by a single dose that is of 300 microgram. The Rosette test is suggested as an initial screening, and it's a qualitative yet sensitive test for fetal-maternal bleeding. A standard dose of anti-D given to patients with a negative test when the amount of fetal-maternal bleeding is small, that is less than 2 ml, or with less than 0.0% of fetal red cells in the maternal blood. And when Rosette test is positive, Kleber-Betke test or fetal flow cytometry is recommended to determine the percentage of the fetal red blood cells and thus deciding the dose of the anti-D that has to be administered. So before I finish, all D-negative pregnant women should undergo an antibody screen at the first prenatal visit. If the initial screen is negative, a repeat screen at 28 weeks of gestation prior to the administration of anti-D. For pregnant women who are D-negative, routine administration of anti-D immunoglobulin early in third trimester, that is around 28 weeks. The optimum dose regimen is 300 micrograms at 28 weeks of gestation, and if possible, to repeat a dose at 34 weeks, but that again depends, it's a controversy, but then studies say that it could be beneficial if it's given twice. But though not practiced much in India right now, it's a single dose of antenatal dose that we give nowadays. Administration of antenatal anti-D is needed when there is an increased risk of fetal-maternal bleeding. Testing for quantifying the fetal-maternal bleed is better done for events after 20 weeks. Repeat dosage of those with repeated bleeding episodes better be decided by results of ICT after 3 weeks. Administration of anti-D within 72 hours of delivery of an D-positive infant is recommended. If missed out, give it as soon as it's remembered, and partial protection is afforded when 13 days, within 13 days of birth, and may be an effect as late as 28 days after birth. So just a point about this, just an interesting fact that was there in the textbook and was a very common question asked by one of my professors. This 72 hours concept, and it was mentioned in the Williams episode then, that used to say that in the jails in England, basically in those days of World War, when anti-D had to be administered, and the hospital used to be closed on the Saturdays and Sundays in the jails. So on Friday, the lady who delivers is ideally supposed to get the anti-D on Monday, and that is why the 72 hours rule came in. But then remember that anti-D has to be administered at any point of time and should not be missed out. That is the main take-home message. So this is a flowchart of that will depict the whole thing that I've just mentioned. So we know when it's an Rh negative mother and a Rh negative father, then it just settles the problem. But then this settlement is only after the baby's blood group is done. And if the father is Rh positive, then a maternal antibody screening should be done, ideally in the first trimester, and a repeat at a 20, 24, and 28 weeks of gestation. If that is negative, then administer a 300 microgram of immunoglobulin at 28 weeks. At delivery, the baby's Rh status of the newborn to be checked. If it is negative, no further treatment required, and if it's positive, then repeat a further dose of 300 micrograms. If it is positive, if the antibody screen is positive, then manage as Rh sensitized pregnancy, amniocentesis, etc., which will be dealt in detail by Vaishali ma'am during her panel. Thank you for the patient hearing, and thank you for giving me this opportunity. Thank you.
Yeah, thank you, Priyankur. You have given an excellent talk, and you have almost covered the entire topic. And all the discussion we will take at the end of the panel discussion. So congratulations, Priyankur. Wonderful talk.
Thank you so much.
Yeah. So I hand over to Priyankur again so that he can welcome everyone, all the panelists, and then we can begin with the panel discussion.
Yeah. So for the panel discussion, which is on clinical scenarios on Rh negative pregnancies, will be moderated by Dr. who is the chairperson of the Perinatology Committee. She is Director of Ops and Gynae in the Shayadri Super Speciality Hospital in Pune, the postgraduate teaching person of the Perinatology Committee 2018-2020, Executive Vice President of the Pune OBGYN Society, has a number of international and international publications and also a number of awards that she has under her belt. Ma'am, truly I should say that it was beautiful working under you actually in this perinatology committee for the last 2 years. You have been so proactive, and there are so many sessions that we have done, and it's actually very nice that you're so academic. We write a lot of books, the Foxy focuses, etc., and it is very nice, ma'am. Welcome, ma'am, for the session, and you will be moderating the session. Next, the panelists. First, Dr. Nilesh Balkawat. He has done his fellowship in reproductive medicine and also is a diploma in gynae endoscopy. He is a clinical head and fertility specialist in Oasis Fertility Pune. He is a joint clinical secretary of Pune Obs-Gynae Society, national coordinator of the quiz committee Foxy, and he stood first in college in all the branches, has got a number of awards and has contributed into a number of books and chapters in national and international books. So welcome Nilesh to the panel discussion. Next, I would like to introduce Dr. Indranil Datta, a close friend of mine. He has done his diploma in advanced laparoscopic surgery. He has done his fellowship in ultrasound, endoscopic surgery, infertility, gynae oncology. He is associate professor at IQCT Medical College in Durgapur. He is the East Zone coordinator under Dr. Alpesh Gandhi for the term 2020-21. He is a past president of the Kalyani Obs-Gynae Society and a secretary of Indian Academy of Obstetrics and Gynae. He has many awards under his belt. Actually, most of the awards under the Foxy category he has received already, and he has written a number of chapters and also edited books in Foxy focuses as well. So welcome Indranil. Next, I would like to welcome Indrani ma'am, a very senior person, a very cheerful person from Shillong. And ma'am is a senior consultant and HOD of the Nazareth Hospital in Shillong. She was the president of Shillong Obs-Gynae Society from 2017 to 19, and the organizing chairperson of the last Eastern Eva Foxy. Was wonderfully attended and wonderfully in Shillong in 2019. Welcome, ma'am. Next, next I would like to welcome another friend of mine, Dr. Prasanna. He is done his fellowship in endoscopic surgeries, but practices fetal medicine basically. He is from Asansol, and he is a director of the Ultra Clinic Fetal Medicine Center in Asansol. He is a joint secretary of the Kolkata chapter of SMF. Welcome, Prasanna, to the session. Next, I would like to welcome Dr. Queen Aditya ma'am. She is a consultant at Ambi Hospital, Narayanan Memorial Hospital, Kasturi Medical Center in Kolkata. She has got special interest in gynae endocrinology, vaginal surgeries, and high-risk obstetrics. She has received the Chief Minister's Gold Medal for being the most outstanding girl candidate in the highest secondary examination in 1988 in the state of West Bengal, and Dr. APJ Abdul Kalam Award for Appreciation from Delhi Gynecologist Forum in 2015. A regular faculty in many gynecological conferences, East Zone Coordinator for Foxy Sexual Health Committee in 2020. Currently member of the Foxy Medical Legal Committee, Foxy Perinatology Committee, and previously member of Foxy Breast Committee. She regularly appears in health shows on various TV channels, publication plus guest editor of Your Health of IMA, and she stood 10th in the higher secondary examination conducted by the West Bengal secondary health examination, and also passed MBBS with honors and gold medal from the Medical College, Kolkata in 1993, and MD from Medical in 1999. Welcome, ma'am, to the session. And last but not the least, I would like to invite the senior most person for today's panel, Dr. Arun Madhaborua, sir. He's a consultant gynecologist, Sampriti Hospital, chairperson of the Northeast ISAR and honorary president of IMA Sibsagar branch, organizing secretary of AICOG 2010 in Guwahati, published a number of chapters in national and international journals and books, faculty to various conferences. Most of the conferences actually are at a national and international level, and as well as workshops. The main interest is clinical obstetrics, infertility, and endoscopy. Graduated from Assam Medical College in Dibrugarh, and is a member of a number of societies. He is an invited faculty to more than 200 scientific congresses. So I invite all of you to this session and hope that we will have a wonderful session and discussion under moderation of Dr. Vaishali ma'am. Thank you.
Yeah, thank you, Priyankur, for the very elaborate and nice introduction. So we move on to the panel discussion today, and as you can see, we have an array of experts on the team. We have senior most sir, Dr. Arun Barua sir. It's an honor, sir, privilege that you are with us today. We have two lovely ladies, Dr. Indrani, Dr. Queen with us, and the young brigade, Dr. Nilesh, who is from my city of Pune. Dr. Indranil Datta and Dr. Prasanna Roy. So, as we have seen in Priyankur's talk, RH negative pregnancy has already covered most of the topics. So, the aim of the panel discussion is basically to discuss the clinical scenarios and the case-based discussion and to give clear-cut messages to all our listeners. As we know, the molecular biology has evolved so much that today we can find out the fetal blood group by fetal DNA. And accordingly, the entire management changes. But with the advances in technology, has our day-to-day management really changed? So for that, let us go on with the panel discussion. So Arun, sir, this question is for you. Dr. Arun?
Yes,
sir. Yeah. So this is the first question for you. This is a case, Gravida 2 Para1 living one, 10 weeks of pregnancy. Her blood group is ARH negative and she has come to the OPD for ANC registration. So my question, sir, is if you can guide us how to go about, is her history relevant? Obstetric history, is it relevant? Is husband's blood group important? And in which way? That is the first part of the question. And the second part of the question is this, that will you advise ICT and when ideally at what gestation age the ICT should be done? Yes, sir.
Okay. Thank you, Vaishali, for giving me the opportunity to lead the elite group. I think me being an oldie, I should have batted last. But anyway, you thought the oldies really deserve to be a little amount of honor. But the clinical scenario that you have given us, she is a Gravida 2 Para1. Am I right?
Yes, sir. Gravida 2 Para1, living one, 10 weeks pregnancy and ARH negative.
Okay. So we have already presumed, we have confirmed that she is rhesus negative. But immediately when the rhesus negativity question arises in the first booking, our question will go to the patient whether you have a documentary evidence of receiving NTD or whether the blood group of the newborn was done immediately or even during her antenatal period. So these are the three questions that normally I ask to my patients. Depending on that, we carry on further investigations. In case the blood group of the newborn, which is not routinely done in every center in our state, that's what I like to stress. Even in today's era, the newborn's blood group is not routinely done in every health center in the country. I like to stress it again and again. That's the only relevant point I'm asking. If the patient can remember that it was done, then obviously if it was positive, I'll ask the patient to confirm whether it was positive or negative. Whether she had undergone ICT in her previous pregnancy. If it is done, what was the result? Whether she was given an antenatal doses or the doses was given postpartum after doing the blood group of the newborn. In case she was immunized with a full dose of anti-D immunoglobulin, I'd be happy, yet I won't take a risk, and I'd like to have a documentary evidence and do a test at the booking to be sure that I remain safe during this pregnancy. Okay. At the same time, I like to also discuss about the options of doing the blood group and also at different time of pregnancy in this indexed pregnancy. Maybe around 16 weeks, maybe again at around 28 weeks, and also discuss about whether we are going to give you one dose or a divided dose of anti-D during pregnancy, or if she decides that, no, sir, I'll take a call maybe after I deliver the baby. So this is an open discussion that normally I do in my day-to-day practice with me.
Thank you, sir. So like as sir has said, it is important to know the past obstetric history, the baby's blood group, whether anti-D was given or no, and husband's blood group is also so very important. And even if we know the zygosity, all the more better, because if there's a the husband is heterozygous, then there's a 50% chance that these babies may be Rh negative, but the husband is homozygous, then there's 100% risk that this could be, all the babies are going to be Rh positive. Past obstetric history, why it is important? Because in the past, if there has been isoimmunization and the fetus has been affected, then it is going to happen during this pregnancy also, and probably at an earlier gestation age than what happened in the previous pregnancy. Like sir has rightfully said, ICT needs to be done on regular basis at regular intervals. So coming to the next question regarding that, Indrani ma'am, this is for you. So we have checked the ICT of the patient and ICT has come positive. ICT positive, what does it mean? It means that Rh isoimmunization has occurred. Probably the hemolytic disease of the fetus has already started, and we are worried about that. So my question to you, Dr. Indrani, is this, that what are the common fetal affections? What are the common hemolytic diseases of the fetus and the newborn?
Yeah. So I'm audible, I hope. Because
yes, you are.
The connection is very unstable. I have lag in between.
Little lag is there.
Okay, so why this occurs actually? There's a lag, I think. Am I audible?
Yes, you are audible now.
Am I audible?
Yes.
Okay. There might be a lag. Please excuse me for that. So what happens is that when the fetal red blood cells, which possesses the antigen, then it crosses which the mother lacks, the antigen the mother lacks, and the fetus has the antigen. So it crosses the placenta and there is antibody production. So this antibody then comes back through the placental circulation, and then it creates an antigen-antibody reaction, and then that results in the hemolysis. So most commonly what we have is, which we call erythroblastosis fetalis, it might be due to ABO incompatibility also, and then Rh incompatibility. That is one of the main causes of hemolytic disease of newborn. Other than that, we might have certain deficiencies like G6PD, glucose 6-phosphate deficiency, then pyruvate kinase deficiency. These are the enzyme deficiencies which might cause hemolytic diseases of the newborn. Then there might be certain hemoglobin synthesis disorders. Certain cases of thalassemia may also present with hemolytic diseases of the newborn. Then like hereditary spherocytosis, elliptocytosis, these can also cause. Then infection like torch infection, parvovirus infection, and if there's sepsis in the fetus, that also causes hemolysis and can cause hemolytic. Then certain drugs, like, the mother has been given too much of oxytocin, that might also cause hemolysis in the fetus. Then vitamin K, too much of excessive vitamin K, if given to the fetus, that can also cause hemolysis and cause hemolytic diseases of the newborn. So these are the certain causes. I hope I could say in one go. I don't know whether you could hear it or not.
Yeah, we could hear you very clearly. Thank you. So hemolytic diseases, like Dr. Indrani has enumerated, and for Rh negative especially, what we are worried about is the hydrops fetalis, which is a very...
Yes, sorry, hydrops, yeah, that was one of them.
And that is the end disease, the end stage. There could be icterus gravis neonatum, which can occur 24 hours post-delivery, or the congenital anemia of the newborn, which may occur up till 5 to 6 weeks post-delivery. So this affected fetus, the hemolytic fetus, can affect the mother also. What with the large baby and the polyhydramnios, there could be preeclampsia, PPH. There's something very interesting known as maternal syndrome, in which there's hypoproteinemia, there's edema and itching, which indicates that there's an imminent fetal death. So coming to Dr. Queen, this is a question for you. All this while we are talking about prevention. of isoimmunization by reducing feto-maternal hemorrhage. But there are some procedures where the risk of feto-maternal hemorrhage is more. So we would like to know which are these procedures and what can we do to prevent this excessive feto-maternal hemorrhage.
So like you mentioned, there are certain natural phenomena that happen during pregnancy, which can also give rise to a fetal maternal hemorrhage. That is, it can be also in a threatened abortion. As a thing as simple as threatened abortion might also cause fetal maternal hemorrhage. But if it is a very minor amount of bleed, then usually we are not that concerned, because if it is below the critical value, that is 0.1 ml, then usually it does not cause too much of a problem to the mother as far as isoimmunization is concerned. Other than this, the natural, if there is an ectopic pregnancy and it is bleeding inside, that will also cause the feto-maternal hemorrhage. If there is a molar pregnancy, then as Priyankur has already mentioned, in a total mole, usually there is no fetal elements, and thereby the feto-maternal hemorrhage does not occur. But if it's a partial mole, then it can give rise. But at times during evacuation, we cannot be totally sure whether it's partial or total. That is why instead of taking a chance, we should consider that to be a feto-maternal bleed as well. Then if we are going for a termination of pregnancy, someone has come for a termination of pregnancy with a Rh negative woman, and the partner may be being Rh positive, then also we should think of consider that to be a feto-maternal hemorrhage. Now, certain procedures, like in the first trimester, when we are going for a CVS, chorionic villus sampling, then that will also might give rise to a feto-maternal hemorrhage. In cases of multifetal pregnancies, when we are talking about reduction nowadays, especially in IVF cases, if we are talking about reduction in an Rh negative mother, that will also cause some amount of feto-maternal hemorrhage. So these are mostly the things that happen in the first trimester. Then in the second trimester, there can be an amniocentesis for any reason. We are going for an amniocentesis, probably in an Rh negative mother, generally for isoimmunization, or for another reason, if for some other cause, if we are going for an amniocentesis. Suppose there has been dual marker, the combined test has come screen positive, then we are going for an amniocentesis. It's not that she is Rh negative, so she will not be screen positive. It can happen. So that can also give rise to an amniocentesis, which again can give rise to the fetal-maternal hemorrhage. There can be trauma to the maternal abdomen at any stage of pregnancy. That can also give rise to a hemorrhage, whether we know it or not. It might be revealed or concealed. So these things are there. So later in pregnancy, specifically in an Rh negative mother, when we are monitoring, we might have to go for a cordocentesis, or for some other reason we might have to go for a cordocentesis. That can also give rise to a feto-maternal hemorrhage. Nowadays, external cephalic version is not practiced, but if in places where it is practiced, nowadays hardly it is done, but if it is done, then that also in an Rh negative mother can give rise to a feto-maternal hemorrhage. And then the things like antepartum hemorrhage, whether that is a placenta previa or abruption, and especially in abruption where the amount of bleed can be very heavy, that is also another concern for feto-maternal hemorrhage, gross amount of feto-maternal hemorrhage. Then at the time of delivery, a normal delivery can also give rise to hemorrhage at the time of parturition. And then if there is a traumatic delivery, it can be more. Where there is hyperplacentosis, where the size of the placenta is more, there can be an excessive bleed. Where we are going for something, a procedure like a manual removal of the placenta, MRP, there also the feto-maternal hemorrhage can be more. So in all of these procedures, we have to think of a feto-maternal hemorrhage in a Rh positive mother, if we are concerned or not, but at least in an Rh negative mother, we have to be very cautious, because that can give rise to a sensitization, and then the whole story, the whole tragedy will begin if we do not take care about it.
Yeah, absolutely right, Queenie. Just wonderfully explained, and we all need to be aware about these incidents which can cause feto-maternal hemorrhage. And before I forget, Queen, we are still midway through the panel discussion, but at the end, on demand, we want a song from Queen at the end of the panel discussion. So we move on.
Thank you.
Thank you, Queen. So we move on to Dr. Nilesh Balkavde. Nilesh, this is a question for you. This is a clinical case scenario. There's a primary gravida with 6 weeks pregnancy. She is BRH negative, and she has had a spontaneous abortion. So will you give anti-D? Is there a need to give anti-D? And if so or if not, what are the explanation?
So we have to see for the husband blood group and whether he is homozygous or heterozygous. If the husband blood group is Rh negative, I think there is no need of giving anti-D in those cases. But if the husband blood group is positive, there are now two schools of thought and different studies coming up. So we have one school which says that anti-D may not be given as the feto-maternal hemorrhage is around 0.03 ml to 0.5 ml. So this there is less risk of sensitization with this amount of feto-maternal hemorrhage. But there is another school of thought which says that as less as 0.3 ml of blood can also cause the sensitization, RS sensitization. So there is no harm in giving anti-D. One thing, especially if you are using a surgical procedure, the risk will increase, as Dr. Priyankur has already stressed on it. So if you are using a medical method for abortion for this, then no problem. It is a spontaneous abortion. Again, the risk is less. But if the surgical method is used, the risk will increase. Regarding the dose of anti-D to be given, the half dose of anti-D is sufficient in such patients. Even dose as less as 50 microgram is also sufficient. So I think 50 to 150 is what the dose. Routinely here we get 150 dose, so we are giving at 150. So I would prefer to give.
Nitesh, yeah, you would go ahead and give. Like you said, there are two schools of thought. Spontaneous abortion. Some people, you know, there have been studies that you need not give because the risk of isoimmunization less. But overall, it is better to give. That is your opinion. Any change of opinion? I, request all the panelists to not restrict it to their questions alone. You can please interact and give your opinions wherever. Yes, sir. Yes, sir. Yes, Arun, sir.
Yeah. In this particular cases, whether giving 150 or 50, we are giving 150 because 50 microgram is not available. Are there any studies being done giving higher doses do any harm to the either mother or anyone? Because I have never come across, I never know as well, because we know for a long time 150 microgram is the lowest possible dose available in the market. But when we were students, we saw 50 microgram doses were available, and at that point of time we really prescribed 50 microgram for this sort of abortions. So can you enlighten us on this issue? Because since the doses is not available, we are giving 150, or there is definitely a need of prescribing 150.
Sir, like you rightly said, actually you can give 50 also, but it is not available. We have preparations of 150 microgram and 300 in over here. So 150 is what we should give. We are usually giving till 12 weeks of pregnancy. And regarding this particular case, the controversy was about spontaneous abortion. Should you give? Like Nilesh said, there's two school of thoughts, but I think sir also agrees that it is better to give. The benefit is more than the harm to the mother.
Regarding
and they have shown that as early as 38 days post implantation, the fetal RBCs are developed. So definitely this dose is going to benefit.
As far as the giving the dose is concerned, we fully agree. But my question was regarding the doses. Whether we have any studies, since I'm not aware of it, whether giving a dose which is higher than recommended is being advisable always, or can we reduce the dose from that particular vial and reduce it to at least
maybe it is advisable. If we get a lower dose, it's better to give a lower dose, but it is needed to give a dose. Whatever is available, the lowest dose available to us now is 150, so we give that. So coming to the next question. Yes, please.
Even when we were in college, then below 12 weeks, we were giving 50, and 12 to 20, if there was a miscarriage or anything, we were giving 100. So anyways, we are giving an overdose. As sir has already mentioned, it was 50 and 100, and post 20, it was only 300. So that was the way it is. So it is a big question, whether the same question that sir is saying, whether the 150 that is available, instead of using whatever is recommended, the actual dose that is recommended, whether we should go for that. It is definitely recommended. What Nilesh said is absolutely right, and you also said the same thing. We cannot miss the dose.
Yeah, the message should be Queen. So the message here is yes, what is available to us is 150 right now. Please go ahead and give 150 is the message here. So the next question I would like to ask Dr. Indranil Datta. Yeah, you're there. So this is again a case for you, Gravida 2 Paravan living one, 7 weeks pregnancy, ruptured ectopic pregnancy. You're a laparoscopist, so you have done surgical intervention. You have done the surgery excellently. And then will you give anti-D to this patient, and how much will be the dose?
Definitely, we have to give anti-D, but as clearly told by Priyankur, and as well as the literature suggests that if surgical intervention is done, and if it is first of all, it is an ectopic pregnancy where there is a rupture, so chances of maternal hemorrhages may be quite high. So usual recommendation which is given in literature is 50, but I would always recommend it is 150. That is what we have been following from our college days. Minimum of 150 microgram has to be given. So irrespective of whatever literature says, because literature everywhere mentions it is 50 is more than enough.
Yes.
But I would recommend it is 150 should be given.
Right, right. So
And problem
yes,
in other
surgical
rural areas
intervention, you will definitely give the cover of anti-D.
problem in rural areas, it is not available also. 50 will never be available. Even 300 we have to half and give as 150.
All right. So then another question to the panelist here, what about medical MTP? Rh negative girl comes for a medical MTP. Will you advise anti-D immunoglobulin?
100%.
100%. Yeah.
Unanimously, yes, madam.
Yes, yes. So I think what we as obstetrician, most of us are missing it. When a patient comes for MTP, we give them MTP pills, but probably many, it is something not done on purpose, but a lot of obstetricians are missing it. So with the medical MTP, with the medical pills, please ensure, ask for the blood group, and whenever required, please give anti-D immunoglobulin to this patient.
I think
any patient who is coming for advice for MTP, we have to get the hemoglobin done, the blood grouping, and the serology as a minimum basic. And then we have to prescribe once they get those reports. And obviously ultrasound, because a lot of practitioners don't prefer ultrasound also. So at least these four should be there to proceed.
For all medical MTPs, whatever gestation, please give anti-D immunoglobulin is the message to be given here. This is for Dr. Prasanna. I know you are a fetal medicine expert, but we want your input later on when we go towards the fetal medicine discussion. But right now the question is this. The case is Gravida 3, Paravan, abortion 1, living 1, 18 weeks of pregnancy, and there has been incomplete abortion. So surgical intervention done, and post-procedure, how much will be the anti-D that you will give? 18 weeks.
Definitely 300 micrograms. Anything above 12 weeks, I will prefer to go with 300 micrograms of anti-D. Before 12 weeks, we can restrict ourselves to 150 because that is the dose which is available to us. But anything above 12 weeks and surgical instrumentation has been done, so we need to give 300 micrograms to this woman.
So absolute very clear message given by Dr. Prasanna, 150 till 12 weeks of pregnancy. After 12 weeks, it is 300 microgram. There's a second part to this question. This is a primary with 16 weeks of pregnancy, and she has recurrent episodes of bleeding PV. So will you give her anti-D, and what dose?
Yes. I will take a history first from her, that from when she is bleeding and whether during her first episodes of bleeding she has received anti-D or not. So if she gives a history that she has received anti-D, then most probably I will repeat the anti-D and I will check that whether it is weakly positive or not. If it comes out as weakly positive, then I will not repeat the anti-D. But if the ICT comes out as positive, I will not repeat the anti-D. But if the ICT comes out as negative after receiving an anti-D previously, then the ideal way maybe is to quantify the amount of bleed by the K-Horvath-Key analysis and then give the actual dose needed. But as we know, practically it won't be possible to quantify. So maybe I will give a repeat dosage of 300 micrograms for her. If the ICT turns out as negative, if it is positive, I will not repeat the dose.
So at 16 weeks, if there's recurrent bleeding, the message here is it is better to give repeated doses, only one dose, and then after first dose, again if she bleeds, it is preferable to give repeated doses, maybe at a frequency of 4 to 6 weekly also, but do not hesitate to give a repeated dose. Now coming to sir, Dr. Arun sir, this is for you. Can you just guide us about routine antenatal prophylaxis for anti-D immunoglobulin, and they say you should give single dose, double dose. So what do you recommend, sir?
I'll be honest to you, because the place from where I come from is not that economically very sound. So I always have to discuss every expenses that I bear. So giving anti-D without knowing the blood group, because we normally do not routinely do any investigation to know the fetal blood group in this part of the country. So the only way that we have an opportunity of knowing the blood group is after delivery. So under the circumstances, I give the option to my patients. I educate them with my knowledge that it is always better to take the doses during the antenatal period to minimize whatever complication that could have been. But this is what the lacunae of medical science is. Technology cannot percolate to every place where it should have been. So under those circumstances, the people have to take a decision whether they will take this particular doses after confirming their blood group, because the price, however small it may be, it matters to many of our antenatal patients. So my clear-cut decision of your question is, I will discuss it thoroughly with the patient. If that particular expenses cannot be a hurdle to them, I will recommend them at 28 weeks and repeat after 32 weeks, 150 microgram doses. Else, post-delivery, it has to be a compulsory doses of 300 microgram.
Right, sir. Sir, if the patient did not have any economical challenges, then in that scenario, would you give antenatal prophylaxis without?
Yes, always yes, because there is always some amount of retroplacental circulation from the fetal side to the maternal circulation, and that can incite enough antibody to have minimal effect on the baby as well. We never know. We do not do any particular test to detect that. So to minimize even that particular complications, I routinely advocate at 28 weeks and 32 weeks if it doesn't cost them hard.
Right. Thank you, sir. So prophylaxis at 28 weeks, 300 microgram is required. They do say you can give 150 microgram in 2 doses, but you know the disadvantage here is if the patient takes the first dose at 28 weeks and does not turn up for the second dose, then that benefit is lost. So better to give the entire dose at 28 weeks. Thank you so much, sir. So this is for you, Dr. Queen. The question is, yes, sir. Yes, sir. Please go ahead.
I have one question. Is there a recommendation anyway? I have never read it, but I have seen prescriptions prescribing full doses of prophylaxis in the primary gravida in the booking itself.
So your voice is a little bit it's breaking.
What I wanted to make it clear is there any guidelines to say or recommend a full 300 microgram doses as a prophylaxis in the booking? Antenatal booking. First, it's 10-week visit.
No, sir. I don't think so.
No.
Antenatal prophylaxis at 28 weeks pregnancy, 300 microgram. Is that what?
10 weeks.
No, he's asking about booking.
Sir is asking at booking visit whether it is recommended. No, we have not come across anywhere.
No, not at 10 weeks.
I have seen prescriptions across the country.
Wrong.
Because we have an ONGC headquarter here, so we get prescriptions across the country where they say that no, it is recommended. So I just keep mum, because I personally do not have an access to that recommendation. But I never negate them, because criticizing our colleague is never a worthy decision. So I just wanted to enhance my knowledge from this forum. Thank you.
No, so like as you guided, it is just antenatal prophylaxis at 28 weeks or 32 weeks. Nothing at 10 weeks unless there's an episode of bleeding, then that needs to be covered. So Dr. Queen, this is for you. Can you just guide us regarding post-delivery immunoglobulin, what dose and when should we give?
After delivery, the first thing we do is we check the baby's blood group. So now if the baby is negative, then we will not give anything, right? If the baby turns out to be Rh positive, then obviously we have to give the dose. As Priyankur very rightly has already told us that it is within 72 hours that we are supposed to give the dose, and he has very nicely told us a story also why 72 hours. As soon as possible we are supposed to give the dose, but and the dose is the full dose of 300 micrograms in case of the usual happenings of a parturition, right? When things are usual, nothing unusual. When there is a heavy bleed, or either there was an antepartum hemorrhage or traumatic delivery, or there was manual removal of placenta, when these kind of things happened and we are suspecting that the amount of bleed is more than that 300 microgram can counter, then we really have to think of additional dose or a higher dose. So the best thing to do is to quantify the amount, as Prasanna had already mentioned. If you can quantify, that will be the best thing. But in our setup, in usual cases, it's very difficult to do so. So it's by our own estimation or our suspicion. When we feel that 300, in spite of giving 300, the woman will become sensitized, then it is better to give a higher dose. In those cases, as I already mentioned, in these kind of traumatic delivery or manual removal, or when there was antepartum hemorrhage, the bleed was very heavy, then we should think of a higher dose. Ideally, within 72 hours, if we want to quantify, then that is supposed to be done between 30 minutes and 2 hours after the feto-maternal hemorrhage, because we have to wait for 30 minutes for us to be able to know what the amount was. If we do it too early, then that will give us a false negative report. So the minimum time should be 30 minutes. And then as I mentioned, 300 is the usual dose. Wherever we are suspecting anything more, if we can quantify, well and good. Otherwise, give a higher dose, and ideally within 72 hours or even before that, as soon as possible. But the message which Priyankur also said, that if we are delayed, it might so happen that it has slipped our memory, mind, and we have not given. Then later, oh, we have not given, let it be. No, as soon as we remember, we should give. Even as late as 28 days or 1 month has also given some protection. As soon as we remember, we should give. We should never not give that dose when the baby is Rh positive. That is the main message, that we should never not give it. We have to give it as soon as possible. The better, the sooner the better. If not, it should be given. And when the baby is Rh positive, no mother should go without an anti-D.
So, like Dr. Quinn has very emphatically said that about the importance of giving this dose, it has to be given. It has to be given. Before you give, you need to know two things. That is the baby's blood group and the direct Coombs test.
Yes.
These two things are essential before you give the anti-D to the mother. And whenever you remember, as early you give, it's always a better. You also mentioned, Queen, regarding the if there's excessive maternal hemorrhage. So that we will discuss with the next question. My question here is for all the panelists. What if there's an intrauterine fetal death? So Rh negative mother, but IUFD, will you give anti-D?
Absolutely, 300 micrograms full dose.
Give.
Yes, definitely.
Full dose has to be given.
Yeah. So I think all panelists agree that yes, you should give. And when should you? Why I'm saying intrauterine fetal death? Because you cannot assess the baby's blood group. At birth, you will not know the baby's blood group. In spite of that, yes, you assume it's a positive blood group and give the benefit to the mother. When should be the timing for the anti-D? The timing should be as soon as the IUD is diagnosed and not wait for the delivery to happen. So that was the trick question. Now coming to Dr. Indrani, this question is for you. This is again a clinical case. Gravida 2 para 1 living 1, 34 weeks of pregnancy with blood pressure of 160/100, and she is diagnosed as abruptio, and she has undergone emergency LSCS with almost a ½ liter of retroplacental clot retrieved. So that means there has been excessive feto-maternal hemorrhage. So how will you manage this patient? What are the tests which you would like to do for feto-maternal hemorrhage? I'm asking you not about the obstetric point of management, but regarding what is pertaining to us regarding Rh negative pregnancy. Dr. Indrani.
Yeah.
We can hear you.
Can you repeat? You want to know about the feto-maternal hemorrhage?
Yeah, this patient has had excessive feto-maternal hemorrhage. So how will you assess that? How will you manage?
So firstly, the mother's management and the fetal management. So,
Dr. Indrani, can you hear me?
which is already
More,
under CS.
yeah, more about less about obstetric management.
Hello.
Yeah.
Your voice is cracking. You know about the obstetric both.
Yeah,
and the
we will not discuss. We will discuss regarding the fetal-maternal hemorrhage.
Voice cracking. Okay, so for mothers, yeah. So already they so bleed. So we need to measure. After the delivery, we will take baby's blood group and send the blood for testing of the baby. And then if it is definitely the baby is positive, if the baby is positive, we will give her anti-D, and we will check for the baby's hemoglobin level, hematocrit, and then the test for measurement, as we know that fetal-maternal hemorrhage, this can be tested by the Kleher-Bethke test. That is one of the tests where you can see the amount. Then we have flow cytometry also, which will also detect the amount of hemorrhage which has occurred. And if, hello, am I audible?
Yes, you are. Yes, yes.
The connection is showing very unstable.
So please go ahead.
You can hear.
Yes.
So as I've said, the fetal-maternal hemorrhage measurements can be done by the Kleher-Bethke test, and a flow cytometry also will help us in detecting the hemorrhage, the amount of hemorrhage which has occurred in the fetus. Hello?
Please go ahead. We can hear you.
Yeah. So that is post delivery. Then we can quantify the amount of hemorrhage. We have a formula also which can quantify the hemorrhage where the maternal hematocrit, and it is divided by the fetal cells in the Kleher-Bethke count. That will give us the exact quantification of how much hemorrhage is there.
Yes, Dr. Indrani, what you have said is so accurate. We have been hearing about Kleher-Bethke test, but now with immunofluorescence and flow cytometry, it's easier to assess the excessive fetal-maternal hemorrhage. Why is it important? Anybody wants to add to this, what Madam has said? Any of our panelists?
Because if you miss the additional hemorrhage, if you miss the additional FMH which has happened, then we are underdiagnosing the woman, and we are giving inadequate doses to her. That is why we need to quantify the FMH if it is really possible to do that. Especially in these settings like abruption or placenta previa or manual removal of placenta has been done. And in these cases, additional FMH might be there.
Yeah, because like Dr. Prasanna said, that if there is excessive fetal-maternal hemorrhage, then we need to give extra anti dose for every 1 ml of fetal blood cell that has entered into the maternal circulation. You need to give an additional 10 microgram of anti-D immunoglobulin.
20
micrograms.
10 to 20 microgram of. So it is, and suppose there are situations like Arun sir said that sometimes it's not possible to do all these tests. For us also, if you order it, there are very few labs around which are going to do.
Vaishali,
so
I don't think flow cytometry is available in India.
Like flow cytometry, Kleher-Bethke, it's good talking about it, but it's practicality, it's very low. So yeah. I think everyone will concur that if we are in doubt, it is better to give a slightly higher dose than to give us less dose, because then the whole purpose will be defeated. Instead of giving a lower dose, there is no harm giving in a slightly higher dose. If we give a lower dose than what is required, then the whole purpose of the entire thing will be defeated. Because even a small amount of excess blood cells will give rise to sensitization.
Correct. So what you are saying is absolutely right. The point here and the message what we want to give over here is, suppose the tests are not available and you suspect that the hemorrhage is more, please give a higher dose, but give that benefit to that women. There have been studies and it has been recommended you can give a dose as you can keep as high as 1500 microgram if required. If you have to give a higher dose, then you can give an IM preparation or you can give an IV preparation also. right? Everybody agrees.
Yes, we can give IV. Yes,
Yes.
we can give IV.
But the IV preparation is a different kind of preparation, not what we are
Yes.
discussing. So there are two different kind of preparation. The intramuscular which we give, is there any specific
give-
site where it should be given?
Deltoid. It has to be always deltoid, because if we give it in the buttocks, the depth of the needle will always be in the subcutaneous tissue and the absorption will not be proper. And if we are giving additional doses, ma'am, like you mentioned that we can go up to 1500, then we should make sure that we should give it in different sites, not at the single site.
Correct.
We should make multiple
Anterior
sites.
thigh, anterior thigh is also.
So since
Deltoid is the preferable.
No, but when you're giving multiple, then maybe two deltoids will be too much.
Yes,
you might
ma'am.
need the thigh as well.
Yes, ma'am.
may I ask one question? Like how much more we can give? Like how we decide that? How to increase the dose? Because we'll not be able to calculate it.
No, if you are giving
That
up
is
to
an assumption
1500,
we are
then
making,
you need
like-
to calculate.
Estimate or a judgment, our own judgment.
Okay.
Yeah, you
Yes.
need to
That-
calculate the the message.
For 1
you are-
ml, 20 micrograms. So that way we can calculate it with our own
Yes.
judgment only.
Yeah. So ideally better to do the test, and only if the test is not available, you give an extra dose for the benefit of the patient. So coming to you, Dr. Nilesh, this question is for you. So this is a patient, her Gravida 3 para 1, abortion 1, living 1, 20 weeks pregnancy, ICT titer is 1:32. That is a critical titer. So that means this is an isoimmunized patient pregnancy. So what is how will you manage? What is the role of ultrasound, Doppler, MCA, PSV? If it is more than 1.5 mom, what does it mean? How will you do fetal surveillance for this particular pregnancy?
So at this patient goes in a very high risk. She has previous one delivery and one abortion. So there are chances we should be always suspicious in such patients of being sensitized and the isoimmunization factor being set in. We have done an ICT titer which is 1:32. Now regarding these ICT titers, we also need to know that different labs have different critical titers. So we have to talk with the lab people regarding the titers. If it is 1:16 or 1:32, what is the critical level for that lab? Yeah. So if the titers are not critical, we may repeat the titer after 2 weeks. But in this patient, since the titers have reached the critical level, we assume that the patient has to undergo monitoring with MCA PSV every 2 weeks. If the titers are more than 1.5 moms, so now this mom is calculated by the actual MCA PSV which we see and the expected MCA PSV for that gestational age by the nomograms available. So if it is more than 1.5 moms, we can wait for 1 week, and then if it's again the same, we can plan a chordocentesis in such patient. And if the hemoglobin percentage is less than 10 gram percent and the hematocrit is low, we need to give intrauterine transfusion for such patient. And this intrauterine transfusion needs to be repeated. Other ultrasound parameters like the scalp edema and signs of hydrops will appear later, where already the fetus has been compromised. So before these signs appear, we need to pick it up on the middle cerebral artery Doppler.
You're so right, Nilesh. I also want Dr. Prasanna's input also, because he's fetal medicine expert.
Critical titer, as Dr. Nilesh has rightly said, that it is different for different labs, ma'am. But we are generally talking here about RHD antigen. So generally the critical titer is 1:32. But if it is a KEL-induced hemolysis, then the critical titer is 1:8. That is why the critical titer will always differ from case to case. But if we consider only RHD, it is 1:32. Once we reached 1:32, we have to see that what gestation the patient is at. That is the most important thing. Because here in India, we don't have cell-free DNA to see whether the fetus is Rh negative or Rh positive. So directly we need to see what gestation the fetus is. If the fetus is showing of more than 1.5 on MCA PSV and the fetus is less than 35 weeks, we need to maybe plan a fetal blood sampling along with concurrent transfusion. If the fetus is already more than 35 weeks and the moms are more than 1.5, the MCA PSV mom is more than 1.5, then we can do the MCA-PSV trend, that whether the MCA-PSV is on the increasing trend or whether it is staying stable. If it is stable, we can continue the pregnancy up till maybe 38, 39 weeks. But if the trend is on the rise, then we need to maybe consider induction or deliver the fetus as early as possible.
Yeah.
So trend of the MCA-PSV is very important once the moms reach more than 1.5.
Right. So what we need to do, we need a teamwork with an expert fetal medicine person, and then probably a very good NICU later on when such babies come out. So it's entirely a teamwork. So coming back to you, Dr. Prasanna, this question is for you. So when will you take the decision to do an intrauterine transfusion? And since you are already doing intrauterine transfusion in your practice, can you just explain to us the brief steps about how you do it?
Intrauterine transfusion, as we will do it when the fetus is anemic. That is the common sense. So when the fetus is anemic, we will transfuse. So what is the criteria? That the hematocrit has to be less than 30% or the hemoglobin less than 10 grams per deciliter. But that we will only know when we sample the fetus. But before that, we need to suspect that anemia is there. For that, the most non-invasive and the best and the easily reproducible tool is ultrasound, that is MCA-PSV Dopplers. So we have many softwares available to quantify the mom values of MCA-PSV on perinatology.com or maybe Astraya or GE Viewpoint. Many softwares are there, and then we will measure the Doppler of the middle cerebral artery, and then the PSV values, if it is more than 1.5, we will plan a transfusion. And intrauterine transfusion, ma'am, it can be previously, when it was started by way back in 1963 by Lilly, it was done intraperitoneally, but that has a lot of side effects and not suitable nowadays. So nowadays it has to be intravascular transmission. So intrauterine transfusion, when we start, we clean and drape the patient. Before that, we need to make arrangement for O-negative donor red cells, which are tightly packed to a hematocrit of about 75 to 80%. The tightly packed is very necessary of 75 to 80% to prevent overload, so that we have to transfuse less blood to the fetus. If we transfuse less hematocrit blood, then the problems of overload will be there. So it has to be CMV negative, hepatitis B, HIV, HCV negative, and then we take the two routes are there. That is, one is in the umbilical vein and one is in the intrahepatic vein. So when the placenta is anterior, ma'am, then it is easier to give in the umbilical vein. But in many cases, we encounter a posterior placenta, and then it is very difficult to reach up to the umbilical vein or the cord insertion site, as we say, that is the placental cord insertion site. Then the better approach would be to give the needle into the intrahepatic vein. And then once we put the needle inside the vein, we confirm that the blood flow is coming out through the needle, and we check the hematocrit at that point. And the idea of transfusing the fetus is to get the hematocrit up to 40%. That is the cutoff. Many institutes can go up to 55%, but never more than 55%. If we correct the hematocrit more than 55%, then the chances of overload will be there. So how much to transfuse? It will depend on the estimated fetal weight and the pre-transfusion hematocrit of the fetus and the pre-transfusion hematocrit of the donor. So there are formulas for that, and we will transfuse till the hematocrit reaches 40%, ma'am.
Right. So doing an intrauterine transfusion does require a lot of expertise. So what is the experience in your center where you are doing this work? How is the outcome?
We have done only two, ma'am. I am a very junior consultant here. So we have done in fetal ascites cases. Because fetal ascites is the isolated fetal, whenever we see fetal ascites, we have to think about anemia first. Whenever we see pleural effusion first, we have to think about aneuploidy first. So these are the basic rules which we might follow. So the outcome is very good there is 95% in 95% cases it will be irrespective of whether hydrops is there or not, the baby will be absolutely normal and there will be no neurodevelopmental delay also. But post birth, obviously top up transfusions will be needed because the baby will have anemia post birth also, because when we transfuse we are suppressing the erythropoiesis of the baby. So after birth, the reticulocyte count of the baby will not be proper because we have given adult cells to the baby. So the baby will definitely need top-up transfusions, and it might also need exchange transfusions or phototherapy. That will depend on the, as you said, a good NICU setup has to be there to understand that what the baby actually needs.
Right. One more question for you, Dr. Prasanna, is this. You mentioned about amniocentesis, Liley's curve, and spectrometric evaluation, the Liley's curve, is it outdated? Has Doppler
those are obsolete. After MCA PhD, there is no role, ma'am. Only role of amniocentesis might be to confirm the fetal blood group because cell-free fetal DNA is not available in our country for fetal blood group.
Right. So Liley's curve is completely out. What we have been studying is completely out. So coming to Dr. Indranil, this question is for you. So this is a isoimmunized patient. So what precautions will you take during a delivery of such a patient? When will you take decision to deliver her or wait on her, and how will you manage?
Yeah, so the main idea here is to prevent the fetal maternal bleed and to minimize the amount of bleed during the process of delivery. So the places where the amount of the bleed some amount of fetal cells can cross over is when the delivery of the placenta occurs. So if you are going for a C-section or even for a normal delivery, the idea is to not to do too much handling into the placenta, like things like manual removal of placenta or too much handling of the placenta or during the delivery process has to be avoided, particularly for this reason. One more thing which used to be practiced by a lot of seniors, and I had seen in my colleges also by seniors, is they used to, after clamping and cutting the cord, and when the fetus has been handed over to the pediatrician, they used to release the clamp from the end of the fetal end of the placenta, just to release the pressure at that point of time. And simultaneously, oxytocin used to be given in the drip so that the placenta expels spontaneously by itself, and there is less pressure on the fetal side of the placenta. They used to do that, but what I practice here is I usually clamp it and wait for the spontaneous expulsion. If it is a C-section, I tell the anesthetist to give the oxytocin, or if it's the delivery, I tell the sister to put the oxytocin IM in the buttock and wait for the spontaneous response. So once this delivery process has occurred, then we have to make sure that the anti-D is given within 48 hours, preferably post delivery. And another thing we do is to confirm the fetus blood group. We take the cord blood also sometimes. So all these are the minimal practices we do to avoid the fetal maternal bleeding.
Yeah, very, very well said, Dr. Indranil, that you should take all precautions to reduce the fetal-maternal hemorrhage, while especially avoid doing MRP and things like that. I wanted one more answer from the panelist about cord clamping. Should you be doing delayed cord clamping or early cord clamping?
Early
Cord clamping. Early cord clamping has to be done.
Okay. Arun sir, you are on mute.
No, it's okay. There is no delay in this. We have to do it as early as possible.
Yeah. So that is what we have been given to believe. But there has been recent studies which have come up, and there has been a publication by the International Pediatric Journal and a lot of papers which show that there is no role of early cord clamping for Rh negative pregnancy. Like delayed cord clamping helps numerous preterm and all over normal neonates. Unless there's an emergency, then you have to do early cord clamping. But as such, there is no role of early cord clamping for Rh negative pregnancy. You can carry on the practice of delayed cord clamping also in Rh negative pregnancy. This was a little bit controversial, so I wanted to clear it up with a study. So we have almost come to the end of the panel discussion with one last question.
Vaishali, do not put us on confusion. You have to give us one direction, whether early
Yeah,
or...
it is not recommended to do early cord clamping. It's not recommended. Okay. So the last question that we have come to Arun sir and whoever any of the panelists can answer in short, because this really doesn't, we hand over our babies to the neonatologist and you do need a good teamwork with a good NICU to deliver an affected Rh negative pregnant lady. So role of exchange transfusion in severely affected newborn. So anybody would like to answer that?
I really transferred the baby to the neonatologist. So I'll not be able to give you any practical things, but definitely the exchange transfusion I see as a modality, and I have been given good results by my neonatologist following exchange transfusion.
Yeah. So like sir has said, if you have a good neonatology backup, then the exchange transfusion can be life-saving for that fetus. Like Dr. Prasanna said, a good intrauterine transfusion. If there's a hydrox baby also, the survival rate of as high as 80 to 90%. Is that right, Dr. Prasanna? And if you do intrauterine transfusion for a non-hydrox baby, almost 100% chance for survival. The same way, timely exchange transfusion is done for even for a severely affected baby. It can be life-saving for the baby. And after exchange transfusion, the care, phototherapy, and then follow-up, a long-term follow-up, almost for 3 months is essential. So I think we have come to the end of the panel discussion. Each of the panelists have answered brilliantly. I am indeed very privileged that I have been here and interacted with the best of minds over here. So I want to take home message from all our expert panelists, one line. Yes, Arun sir.
Okay. Now, I was chairing the Food, Drugs and Medico-Surgical Equipment Committee of our honored federation from 1999 to 2003.
Okay.
That time, I tried to get down the price of NTD because at that point of time, the price was exorbitant around 2,500. But I tried to negotiate with the company and they have agreed. The manufacturing cost at that point of time was hardly 450.
Wonderful.
So you can just have a look at the levels where the price goes up and the poor patients cannot really buy this both important medicines, which has become almost a life-saving for many of us. So one small recommendation, the gynecologist can take this forward and help out the antenatal rhesus negative mothers by offering them at a subsidized rate. I am sure our people will bless us and that blessing will take you to a greater height.
Right, sir. Thank you, sir. Thank you. Anybody else?
So if we have...
I want to give a message. It's okay, Nilesh, you go ahead.
So I talked about giving anti-D in a case of abortion. So I would just like to make a pointer on that. May the risk of abortion, the fetal maternal hemorrhage be less in a case of abortion, spontaneous abortion, but anti-D has to be given in such a case. If 50 microgram is not available in our case, we can always give 150 microgram till 12 weeks of pregnancy.
Right. Yes, Nilesh, that's right. Yes, Queen.
Yeah. So Dr. Bhaskar Pal right at the beginning said that this Rh isoimmunization is a situation which has seen a huge change because of education, because of our knowledge, and thereby we should make best use of this knowledge, and we should educate our patients also when they come to us with an Rh negative pregnancy, so that in today's day, if not zero number of babies, but the fewest number of babies suffer because of Rh isoimmunization. Like sir said, Dr. Madhav sir said that in the rural parts, there is still ignorance and non-availability, so it is still there. But at least in cities, in metros, this should not happen, and everyone should be educated about Rh isoimmunization. They should receive their doses of anti-D, and no baby should suffer because of the same.
awareness is very important, not only amongst patients but the obstetrician also. Yeah, anyone
I want to say something,
Yes,
ma'am.
because after, as you mentioned, after MTP or after medication MTP, there are a lot of people who have not received their anti-D, and especially in unmarried pregnancies, where there are unwanted unmarried pregnancies, where it's totally a hush-hush phenomenon, and there they come to us later and they are isoimmunized, and it's such a big shame. So everyone should know about this, and the awareness should really be as much as possible, so that not a single woman who is Rh negative goes in any kind of obstetric procedure without receiving an anti-D.
Very emphatically put, Dr. Queen. Thank you. Anybody wants to add? Because then we'll take a few questions which are directed to our panelists. Yes. So should I go ahead with the question? This is a question from Professor KB Subuddhi. Is there any grading of DCT, of direct Coombs test? Anyone can answer.
Whether
Priyankur?
it is positive or negative, that is all.
No, there is a grading, right? The titers which we do, like you said just now, 1:32 is a critical titer.
DCT or ICT, ma'am?
ICT.
Oh.
Okay. ICT that
Can be
1:16,
titers can be
32,
graded,
64.
or even the exact value also can be assessed. Like they say,
Yes, the lab.
4 to 15 international unit per liter is, less than 4 it is safe. 4 to 15 means this affection to the fetus is more. More than 15 means this is severely affected fetus. This is a question by Dr. Caroline Jumbo, and the question is a patient required to take anti-D after delivery if she had received 2 doses antenatally?
Totally, absolutely. Antenatal dose will prevent that minimal amount that happens after. Actually, initially only the postnatal dose was given. Later on, it was found that after giving the postnatal dose, still there is a minimal percentage of sensitization. To prevent that, the antenatal dose was started. So it cannot be a substitute to the postnatal dose. It is only an add-on. The main, because the main bleed, fetal-maternal hemorrhage, will be at the time of the delivery itself. So if we do not cover that, then the whole thing is falling flat. Only that 2, 3, 5%, whatever was happening of isoimmunization in spite of the postnatal dose, that was for that reason we were giving an extra cover. But that extra cover, whether it is 1 dose or 2 dose or any number of doses, cannot do anything to the perinatal bleed that is happening during the delivery process itself. The fetal-maternal hemorrhage has to be tackled, and that will only be done with the postnatal dose.
There's one more question. If the patient has had cesarean and tubal ligation, will you still give anti-D to this patient?
Yes, I will tell you this. What I do is that in these kind of cases, I discuss this with the couple before the delivery, because even if they are opting for a tubal ligation, in today's day, you never know. Tomorrow they might ask for a recanalization. Suppose there have been cases cited where they lost the children because of an accident or something or some disease, and they later wanted another pregnancy. Nowadays, with IVF available, ART available, they might want further pregnancies. And in that case, if they do not receive anti-D, then later then we cannot help them in any way. So this discussion has to be done before we take the patient to the theater with both the couple.
Yeah. And there's
I want to add another point, ma'am.
Yes,
I want to add another point.
Yeah.
Regarding this giving anti-D to this post ligation, I mean, if we are ligating the patient, sterilization, if we do not give anti-D to this woman, they might undergo alloimmunization, and this alloimmunization might hinder with cross matching of the patient later on if she has to receive transfusion later on. So it is better not to alloimmunize the woman and give the anti-D to her, even if we'll ligate the patient.
Absolutely. So even if you have done a tubectomy, it is essential to give anti-D. There's one more interesting question. If patient gives history of affected fetus in the previous delivery, and there has been isoimmunization affected fetus. So in this present pregnancy, how will you manage? Will you be doing ICT for this patient? Anybody can answer.
Previous
Previously
isoimmunization.
sensitized woman.
Yes.
Yeah, previously sensitized. If the fetus has already been affected in the previous pregnancy, then we know that she is ICT positive. So then we directly go to the
Yes.
then we can directly go to the titers, and if the titer is critical, then we go directly for the fetal monitoring by ultrasound, by MCV.
Yeah, absolutely right.
Yes, ma'am.
This is a absolutely accurate answer. If she is already isoimmunized, then the management of this pregnancy completely changes as per isoimmunized patient.
We will directly go to ultrasound.
Yeah. There's one more question by Dr. Shirin that if a patient has missed anti-D at 28 weeks, can you give it later on for prophylactic antenatal anti-D?
Yes, since we are talking about two doses, once at 28 and 34, and we've missed at 28, we can even give it at 34, 32, anytime we can give it. Is something is better than nothing. So there is no harm in giving. Here it is always better to be proactive than to be laid back. In this particular case.
Right. All the answers have been given very well by our panelists. There are a lot of questions, but I think most of the questions we have already covered in the panel discussion. And I would like who else? Someone else wanted to make take home message by.
Yes, ma'am. I wanted to make a point that just a general single line point that please don't abort whenever you see a hydrops or maybe a fetal ascites or maybe an effusion. There might be several other causes, and it might be just a simple case of chylothorax, which we are aborting if we are seeing a pleural effusion. So my message would be very clear as a fetal medicine people that please don't abort once you see an hydrops.
Yeah, so very, very clear message by Dr. Prasanna. And even if there's Rh negative hydrops also, these babies are also salvageable by our expert fetal medicine, and they have very good prognosis. So we have had a wonderful panel discussion. Thank you to each and every one of you, Dr. Arun sir, Dr. Prasanna, Dr. Indranil, Dr. Queen, Dr. Nilesh, Dr. Priyankur, Dr. Indrani. Thank you from Perinatology Committee FOXY on behalf of the committee. Thank you to Science Integra, TOG, and Bharat Serum for this wonderful webinar. And before this, we are, since a long time, we are waiting for Dr. Queen's song. So before we end, I request Queen to please.
Are you sure you want to hear a song?
Of course, we have been waiting.
Okay, two lines I'll try, because this is dedicated to all of us, the frontline warriors of today's COVID situation. We are also demoralized. Every now and then, everyone is getting demoralized. So just trying to put in one or two lines. Please bear with me, because this is totally unprepared. Okay. जीवन के दिन छोटे सही हम भी बड़े दिल वाले कल की हमें फुर्सत कहाँ सोचे जो हम मत वाले जीने का रंगीन मौसम ये खूबसूरत ज़माना जीने का रंगीन मौसम ये खूबसूरत ज़माना अपने यही चार पल है आगे है क्या किसने जाना जीना जिसे आता है वो इनमें ही मौज मना ले कल की हमें फुर्सत कहाँ सोचे जो हम मत वाले. Thank you so much.
Yeah, thank you, Queen. You are indeed so melodious, beautiful.
So this was dedicated to all of you, me included, all of us who are really what we are doing in today's situation, where people are sitting back home and working from home, and what we are facing. This is for us.
Yes, yes. Thank you. Thank you.
Wonderful.
We don't know what we have in store, but we have to live in this itself. This is our life. We have to live in it, and we have to make the most of it. If we think that this is the only time we have to live in this moment itself. So congratulations to all of you for what all you are doing in today's scenario. Thank you. And thank you so much, Vaishali, for giving me this opportunity.
Thank you. Best wishes to Dr. Nilesh Balkaude and Dr. Indranil Datta in the upcoming elections. And
to you too, Vaishali.
Thank you.
Thank you, Vaishali madam, for such a wonderful panel. Thank you all the fellow panelists. Thank you.
Thank you, everyone. Thank you to all the people who have
We had a
logged
wonderful
here
time. Thank
today.
you so much.
Thanks a lot.
Really honored to be here. Thank you, Vaishali. Thank you from the bottom of my heart. Thank you.
Thank you. Thank you so
And
much.
thank you, Priyankur, also for having us.
Thanks, Priyankur. Yeah,
Yes.
buddy.
Thanks, Priyankur.
Many thanks to Priyankur for organizing all this. Thank you, Science Integra. Thank you, TOG. Thank you, Mr. Subut. Thank you, Session. Thank you, Sana, for this arrangement. Thank you, Bharat Serum. Thank you, everyone.